Yes.
Earlier this morning, you described some of the significant physical symptom burden faced by patients with advanced liver disease. And your report notes that physical symptom management is a hallmark of good palliative care. What does good physical symptom management look like for this group?
I might defer to Fiona.
Yeah, so I think there are two aspects to that. There are you need to look for them, so you need to actively inquire about symptoms, and there has been some research that shows that we're not necessarily very good at that. And then you have to try and address those. In trying to address symptoms, the difficulty is there isn't really a good research evidence base that demonstrates safety of particular painkillers in particular that we might want to use. So it's really hard to have high-level research to guide clinical practice. We have tried to put together pragmatic guidance that will ensure safe prescription of not just painkillers but various other drugs for the symptoms that you might experience in liver disease. But I think following basic principles of identifying the symptom, assessing the severity of that symptom, trying to choose a medication that might help, and then reviewing that person is a good framework for trying to help clinically. In terms of concerns, I think specifically around opioid analgesics or strong painkillers like morphine and other cousins of morphine, the worry about people with decompensated liver disease is the risk of hepatic encephalopathy. And one of the ways that morphine tends to work is it slows your gut down, so it can make you more constipated. And the worry is that constipation can then bring with it hepatic encephalopathy. So there is a lot of reluctance, I think, amongst clinicians to prescribe painkillers that, while they might help a physical symptom, they may lead to an unwanted effect. So sometimes I think that leads to people not necessarily having their pain needs met. And I wonder if Hazel or Ben, you have more experience of kind of clinical day-to-day aspects of that amongst yourselves and colleagues.
I think that's one of the problems is there is a lot of kind of myth around it. And so the difficulty is that patients with advanced liver disease are not usually included in clinical trials. In fact, they're usually excluded. And that means that, therefore, drugs companies will often have to say, use with caution. And it doesn't necessarily mean that these drugs do cause problems. It just means we don't have the evidence to say that they do or don't. And yes, with opioids, there is a known risk that they can cause constipation. Now, actually, that can often be mitigated by, if you explain what we're concerned about, then we can increase laxatives and try and manage it that way. And that's about that patient education and what you're trying to achieve, what are the priorities. If someone's got significant pain, actually, they may well accept a certain amount of encephalopathy if it means that you've managed the pain. But it's very much on an individual patient basis. There's also problems even with paracetamol. A lot of patients will have been told by healthcare workers that because they've got liver disease, they can't have paracetamol. And so some of it is just about breaking down the myths, understanding, that you can have them, but that we just need to monitor them. And then, some of the other symptoms like the ascites, trying to manage that in a way that has the sort of the least impact on quality of life. So rather than people coming in as an emergency, it can often take a few days to find someone who's able to insert a drain. So you're in hospital for a few days. A lot of hospitals now have day case services where patients can ring up and make an appointment. So they're coming in just for one day, they have the drain, they go home again, which is really helpful. Or in some cases when people have even more advanced disease and actually even just coming into hospital for a day is quite difficult, they may have a permanent drain put in, which is something which is quite a new area within liver disease. Previously, we thought that the risks of the drains were too high. Now the evidence is that for certain people, they may well be helpful, but it's a conversation to be had with the patient about what their priorities are. Is it coming into hospital? Is it staying at home? And so it's, as we've talked about, it's very individual, but I think there are a lot of myths around it, and there is quite a lot of breaking down of those myths to happen because a lot of them will have come from healthcare workers and patients being just told they can't have any painkillers. And then you have to try and understand where that's come from and sort of explore that and maybe change some ideas and change the ideas of healthcare workers as well.
And you've noted that a further hallmark is addressing psychological and spiritual needs. Why is that particularly important for patients in this group?
I think we touched upon it this morning. I think people's experience of their journey through a healthcare system and the conversations they've had with clinicians and other professionals around them might influence their experience of their illness, their thoughts and feelings towards healthcare services, their thoughts and feelings towards their own health, the impact that that's had on their life. And that can have a huge impact on psychological well-being. I think there's a recognition that psychological well-being and physical symptoms are often interlinked. And for some people who have physical symptoms, if their psychological needs are not met, their physical symptom burden can escalate. But also, if you try and prescribe medications, for example, for those physical symptoms and you don't meet those psychological needs, sometimes you don't actually manage to get on top of those physical symptoms because they are in part being driven or being perpetuated or made worse by their psychological symptoms. So I think it's incredibly important to try and meet both needs.
And who should be responsible for meeting those needs or enabling those needs to be met?
So I think it's, again, comes down to what that individual requires, and it's an assessment about what needs they have and then trying to direct that person to the people who are best placed to meet those needs. It often starts with a hepatology or a gastroenterology team trying to assess what that person's needs are. If they can be met by their index team, then that can be done very easily by that team. It may well be that that person needs extra needs or has extra needs, and it's about trying to work out what services are around locally, because they will differ across the UK, and then trying to appropriately plug that person into the support system that might be there.
And you also address social and financial needs. What are the particular issues in relation to that?
So for a lot of people with liver disease, they are of working age. So having a diagnosis of advanced liver disease or decompensated disease has a huge impact on their ability to work, for example, themselves. And that then has a huge impact on their financial situation. Similarly, the cost to people around them of being a main caregiver and the consequences to them of having to drop the hours that they can work or stop work completely can have a huge impact on the financial situation of that household. And there are a lot of studies that describe huge costs of unpaid care and the detrimental impact to family units on that. So trying to make sure that people have access to the support that they are entitled to, again, that varies across the UK, but just being able to signpost somebody to those services can make a huge difference.
And another hallmark that you've identified is coordinating care across the physical, psychological, psychosocial, spiritual and financial. What does good palliative care and coordinating care look like?
So I can start, and please add to what I say, but I think it starts with an honest conversation, as we spoke about this morning, about prognosis and illness and what that means, trying to address all the domains of someone's care. After having those important conversations, making sure they are documented somewhere that is accessible to all of the healthcare and other teams involved in the care of that person. And it's not just healthcare, social care teams, when somebody becomes more debilitated and is able to do less for themselves, becomes more important. And teams being able to speak to each other is really important in trying to have a smooth transition between healthcare settings, so from hospital to home, for example, and making sure that everybody has that information to hand is very important. So making sure that the hospital team is aware of all the important conversations that have happened, and if somebody then goes home, making sure that that person's general practitioner knows, that the district nursing team, the community nurses are aware, that the palliative care team, if they are supporting that person in the community, that they have access to that information, and that is shared, but also shared in real time. So as someone's condition changes and their needs change, that information is updated appropriately. So being able to coordinate all that very often results in a better outcome for that person. But it's not there yet.
Yeah, I think one of the challenges is that historically patients with liver disease have been looked after in the secondary care setting, and that can mean that a lot of GPs don't necessarily feel very well equipped to deal with people who, particularly where they've got quite advanced disease. And so trying to, but it may not be appropriate for patients to necessarily be coming to hospital, and that may be against their needs, but then we do need to be able to provide the support to the community teams so that they don't feel that they're having to make decisions that they're not necessarily either having the confidence or the experience to manage. And so there have been examples where, I say, the specialist nurse is acting between community or having helplines and things like that to try and meet those needs. But again, all of these things are quite patchy. The psychological support available is very patchy in terms of being able to get specialist psychological support for patients. Financial support, there in some places, for example, Macmillan are able to help with benefits advice, but in some places that's only for patients with cancer. In other places it is for patients who've got life-limiting conditions. The carer support, it's all, a lot of it's charity-based and therefore very, variable throughout the country.
I want to pick up in just a moment the extent to which palliative care meets your hallmarks. Just the final hallmark that you've identified is providing caregiver support. What are the particular pressures faced by carers of patients with advanced liver disease that might perhaps be different to other groups receiving palliative care?
Yeah. So I think the uncertainty can make that journey incredibly difficult. I think sometimes when a caregiver is standing by or is involved in the journey of a patient, it's characterised by lots of hard to predict or hard to plan events, lots of emergency admissions to hospital, lots of reactive care. Sorry, I've lost my train of thought.
Yeah, I think so. It's possibly not so much relevant to the inquiry, but one of the issues is there can be quite a lot of guilt attached to a diagnosis of liver disease for a lot of patients we see, whereby the patient may feel, as we said, unworthy of care because of the fact that their liver disease may have come from actions that they, did to themselves, either ongoing or previously. And that can lead to some challenges with relationships with family members. So what we find is, as Fiona mentioned, when you're having conversations about palliative care, we would always like there to be a carer present. Not all of our patients have a carer because potentially some relationships have broken down over time. Sometimes those relationships can be rebuilt at the point of when things have become very difficult and the patient is reaching the end of life. But then there can be quite a lot of guilt both ways. Carers feeling that maybe they could have done more, patients wishing they'd done things differently. And I think that's sometimes where the palliative care team really, I've seen it being incredibly beneficial because they do provide that support to the family as well and can help negotiate some of these feelings that come up, and actually unfortunately after death as well, where there can be a lot of guilt, where people feel they could have done more. And providing sort of ongoing support to bereaved carers can be really helpful. And I think that is one of, it may not be as relevant to people within the group of the report, but these feelings can be quite challenging, and the burden for carers, particularly with encephalopathy, where it can be very difficult to see someone who you care about change to the point where you barely recognise them, and then try to provide that support in a home environment. And so whilst a lot of people would say they would like to die in a home environment, that may not be appropriate for some of our patients with advanced liver disease, because actually the care requirements are beyond what we could really expect non-specialists to be able to do. So I think the carers, for this group of patients particularly, there are lots of challenges that maybe are not the same as for everybody.
Yeah, you've helped me find my train of thoughts. Apologies. The encephalopathy side of things I think is incredibly difficult because you're dealing with somebody as a carer that you love who is not the person that you know. I think because of the personality change, the cognitive change, the behaviour change that happens, that can be incredibly distressing. And not being able to predict when that happens is very difficult. I think also as a caregiver, you're faced to make quite difficult decisions sometimes in the absence of having the person that you love being able to say to you at that point what they want. So if somebody is confused to the point where they're at risk of harming themselves, but they have previously said, I want to be at home, you're faced as a caregiver with making a decision that you feel is betraying that person's wishes, but ultimately what you want to do is keep them safe. So I think that's a small example of how difficult it can be to be a caregiver. But adding to that, I think caregivers have described to me it being a marathon and not a sprint. I think because of the prognostic uncertainty, people steel themselves for, if they are told by a clinician, your loved one may live weeks to months, it's quite a variation in a time frame to get your head around how long you will be a caregiver for. And if that time frame that you are given is extended because somebody lives longer than is anticipated, I think that can be a difficult burden as well, because somebody may well be glad that their loved one is still with them, but equally that comes with it a big care burden. And so I think for carers there are a lot of complex feelings, understandable feelings of guilt, of concern, of worry, of loneliness. And I think trying to meet those needs can be quite difficult when you don't necessarily have services to be able to wrap around those people across the UK.
And just in terms of guilt, the inquiry's heard evidence, particularly from parents of children who have been who have been haemophiliacs, people with haemophilia, who've been given blood products, often by the mum, of guilt or of having given blood products. How would that play into what you were discussing around guilt in terms of advanced liver disease later on?
Yeah, I think, again, it's very difficult to comment generally on what will be an individual's experience, but I would imagine that that brings with it concerns that are ongoing, and not just at the time of being a caregiver, but as Hazel touched on, in the bereavement response, it may well play into a more complex bereavement reaction. That, again, I think a hallmark of good palliative care would be to meet that need.
I want to move on then to explore with you the extent to which palliative care in the UK demonstrates those hallmarks, those quality hallmarks. First of all, could you just describe how palliative care is delivered when a patient is in hospital, and whose responsibility is it?
Yeah, so in terms of people with liver disease, we speak in our report about core palliative care versus specialist palliative care. So core palliative care would be good palliative care that is delivered by the team of professionals looking after that person. And that is the doctors on the ward, it's the specialist nurses, but it's also the ward nurses, the doctors in training who are also on the ward, and all of the other very relevant professionals who feed into that person's care. So people like dietitians, occupational therapists, physiotherapists. So a big team of people, all of whom will have skills to be able to deliver good palliative care at ward level to that person. If somebody has needs that are more complex that might not be met by that team, then they may make a referral to a specialist palliative care service. So they often work, and certainly that's the case in the hospital I work, in an advice and liaison capacity. So they don't come along and take charge of that person's care. They come along and work alongside the ward team to provide extra support and input for that person in the hospital setting. And again, in terms of the professionals that are involved in that, we are a team of nurses, doctors, we have a specialist pharmacist, all of whom could get involved in that person's care. So it's really the person who can most meet their needs. And then we have access to, as the ward do, the wider team who might also help. So we have a really good chaplaincy service who might be able to meet spiritual needs, for example. We have access to services who are able to provide financial assessments that are able to provide that support as an inpatient.
And when might a hepatologist refer to a specialist palliative care team? What would be the triggers for that referral?
So again, I think that differs across the country from team to team, but speaking in my experience, I would welcome a referral from anybody in the clinical team looking after a person who is in hospital with a decompensation from their liver disease, because to me that's prognostically significant at the very least. But we are talking again about needs, not diagnosis and prognosis. So I think there's very often need that is uncovered at that point.
I think it depends a little bit upon the skills and the confidence of the primary team, because so when we're training, we don't get specific training in palliative care. We will pick it up along the way, and depending on our levels of interest, we may do further training. But the sort of advanced communication training that palliative care physicians would have, we as non-specialists wouldn't necessarily have that. And so sometimes the point at which you refer to palliative care, it sort of depends a little bit on your comfort with how far you can take these conversations and things. So that's why it will vary.
And then in the community, how is palliative care generally provided?
So again, you could describe core palliative care, if you like, and specialists. So many general practitioners, GPs, will provide excellent palliative care in the community, and the people that they work within their team will also do so. So district nurses, community nurses, and people that they caring organisations, formal carers, will also provide good palliative care through hands-on care. If that person's palliative care needs can't be met by that team, then they may make a referral to a community palliative care team, which is based in a hospice, but there are different aspects of that service that can meet different needs of that person. In broad terms, they are a day service where somebody is well enough to attend the hospice unit itself, but as a day patient, and there are lots of services they can access and their family can access. If somebody is not well enough to attend a day service, they can be assessed and supported in their own home by a nurse specialist in palliative care. Sometimes a doctor will go out and do a domiciliary visit if there's extra complexity from a medical point of view. And then finally, there are inpatient beds within a hospice setting, so specialist palliative care inpatient unit beds. And they are generally speaking used for people who either have complex symptoms, where a period of assessment and trying to manage those symptoms by the whole team in that inpatient unit will hopefully benefit them. And if they are at the point where they no longer require specialist inpatient palliative care, then a decision will be made about that, and plans to discharge that person to another appropriate care setting will be made. The other main reason that people will use a hospice inpatient bed is to receive end-of-life care. So if they wish to be in a hospice setting to die, then they will be referred there and they will spend their last period of life there.
What's your experience of the level of knowledge that GPs have about viral hepatitis and advanced liver disease generally, and how that affects their ability to assist and provide palliative care?
It's like all of these things, it is variable, but traditionally liver disease and complex liver disease has been managed in the secondary care environment. And that is sometimes countercurrent to the needs of patients as they approach the end of their life, when they would, when there's a preference to be managed in the community. There was a very good Scottish study a couple of years back that looked qualitatively at general practitioners managing advanced liver disease, and highlighted very widespread gaps in knowledge, confidence, both in the sphere of understanding the prognosis, managing the complications, and that is historically because liver disease has been a hospital condition. How and there's also an important study that's showing as patients approach the end of their life with liver disease, it is common that patients value being out of hospital very highly. And so how we reconcile those two facts, that professionals that work in the community don't necessarily have experience or confidence managing liver disease, with the fact that patient need, as we've discussed, frequently relates to a desire to be managed outside the hospital environment, does need us to rethink how we provide care for patients with advanced liver disease, and rethink the role of hepatologists as being purely a doctor that works in a hospital setting.
Yeah, patients are also used to getting the information about their liver disease from secondary care physicians, so actually sometimes the patients don't necessarily trust the information they're being given by the GP, even if actually the information is entirely correct. And there's evidence that GPs want to be more involved, but I think it's a case of us trying to provide that support with patients who do have very challenging symptoms to manage, etc.
And it is complex. Prescribing for physical symptoms in advanced liver disease is not easy. It's something that hepatologists need guidance and guidelines on, and I think that there does need to be a role for hepatology within community settings, as well as being as a hospital-based specialty.
And from a palliative care perspective, how should the secondary care in hospital interrelate with the community palliative care work?
I think it's really helpful whenever you have the view of a hepatology team as to the stage of somebody's illness that they're at, the options for them in the future, and their overall view as to what their outlook, their prognosis might be, and trying to have some sense of what might be deemed an appropriate intervention. For example, an admission to a high dependency unit if they were to become critically unwell quickly, can very much help to frame how you then start to care for that person. If I give an example, if you have somebody who is very much at the end of their life and they are in bed all the time and they need a lot of help and care and support because of their liver disease and they are going home, it's incredibly helpful to have a hepatologist say, in my view, I think the focus should be supporting that person with their symptom, their physical and their psychological well-being, rather than bringing them back to a hospital setting to try interventions that have very minimal chance of helping. That then really helps to frame conversations that happen with the clinicians and the teams that are community facing. So the GP being able to have a conversation with a patient and their family about the logistics of staying at home and what that would be like and what support is needed. Similarly, for a community palliative care service, it's incredibly helpful to know if you are going to be looking after somebody in a hospice setting, that is not an acute hospital. And so the interventions that are available to you in a hospice building are very different to in an acute hospital where you have access to endoscopy services, to high acuity or high dependency beds. So if somebody is felt to benefit from being in an acute hospital setting and having access to those facilities, that might impact on your decision as to whether you bring somebody into a hospice setting or whether you might try and provide palliative care input in a hospital setting, recognising that there may well still be active interventions available and helpful to that person. But none of that, I think, is as important as what the person themselves would want. And so that has to feed into those discussions as well. So it's not just a one-sided hepatologist, in my view, saying this is what should happen. It should be something that is a discussion between the patient and the team, I would say.
And what's your experience of how all of those parts of the jigsaw fit together currently? How well do they work together?
It is a developing subspecialty, and palliative care in liver disease, if you go back as short as sort of 5-6 years, wasn't really a thing. It wasn't really considered. There was very little literature about it. And so naturally there is a lag in the development of these services. When it's done well, I think it looks like a team sport. It's a multidisciplinary team that meet frequently about patients that are known and are iteratively reviewed, and patients are able to access care that's appropriate for them from the right professional at the right time. I think the development of that model of care is very dependent on the energies and interests of local clinicians in that local hospital that will have to push for it, will fund it, often do it in unfunded time. It's not work that is tariffed, it is not work that is charged, it's not work that is commissioned. And to allow these services which demonstrably improve quality of life to become more ubiquitous, there needs, I think, to be some recognition of the time and the funding and the need for it and the value of it.
We're going to come to those suggestions that you've made in your report of what needs to be done going forwards. Just before we do that, in terms of how the UK care meets the hallmarks, what data is available to us about what palliative care is actually being provided to patients with advanced liver disease?
So I think the short answer to that is very little. There isn't really any single universal repository of information about the standard of services that are being provided. So it's very difficult to know what is going on across the country.
You've talked in your report about the second atlas of variation for liver disease in England as one document that provides some indication of the difference in healthcare provision slightly more generally. Firstly, can you tell us what the atlas assesses? What is the data in the second atlas?
The Atlas of the Public Health England Atlas of Variation looks at a huge range of outcomes in general hepatology, relating from early diagnosis of liver disease in asymptomatic populations through to, for example, in our sphere, the provision of a day case service to have your ascites drained so you don't need a 3-day, 4-day hospital stay. It will look at mortality rates from liver disease the admission rates for patients with alcohol-related disease and provision of services for patients with alcohol dependency, rates of diagnosis and treatment of viral hepatitis, and paediatric hepatology. So it looks at relatively crude kind of high-level data outcome measures across the UK. It always has to be interpreted slightly cautiously because the demographics of the populations it compares are very different. So the populations with hepatitis B, for example, will be very different in hospitals that serve an immigrant population rather than a kind of rural British population, for example. Similarly, there are very strong correlates between mortality and acute admission with liver disease alongside deprivation, which is not a hospital factor, it's a societal factor.
I think one of the challenges of it, we have to say, is that there has to be quite easily measurable outcomes at big level data. There is actually atlas of variation for palliative care, and one of the challenges that they found when trying to compile that report was measurable outcomes for palliative care that you can get at sort of national level data are very difficult. We often use proxy of place of death because that's an easily measurable outcome, but that doesn't give you any idea about the quality of that death, really. Unfortunately, people can have very good deaths at home and they can have very unpleasant deaths at home, and that information you can't get at the kind of level data that Public Health England have access to. And so I think that's one of the challenges of trying to assess palliative care provision for our patients, because you can't, on a national level, you can't have access to that information very easily. That's something you can really only look at when you're looking at your own data and you're almost looking at the notes level data rather than the things that are put into a coding episode for when someone's been in hospital.
Yes, no, we tend to make important the things that we can measure, and the meaningful interventions in palliative care are often much more nuanced than a database can express.
But even at the high level in relation to liver care provision, it's right, isn't it, that the second atlas indicated that there was very significant variations across the country, both in provision and outcomes for patients with advanced liver disease. That's what you've flagged in your report.
It in terms of wider outcomes for liver disease as opposed to palliative care in liver disease, yes, it does make those conclusions. And there is a difference in mortality, difference in the rate of patients admitted with a liver disease complication that are admitted to an intensive care unit between trusts. So there is variation in hepatology care. I think that is true.
And this data is in your report is from England. Is there any reason to think that the position would be any different in Scotland, Wales or Northern Ireland in terms of there being significant variation in liver care firstly?
I mean, you could assume that the similar factors would apply, that hospitals that had perhaps a slightly larger departmental size, had more subspecialty hepatology, may be able to provide a different level of service. But that is an assumption unless people know data that I'm not aware of.
No, I think that's a difficulty. There aren't any formal data to support that, but I think it would be a reasonable suggestion to make that there will be variation across the country. I think it's very difficult because different populations in different geographical areas will have different needs, and there might be, for example, a cohort of patients being cared for in a liver transplant liver ward that may be very different to patients that are being looked after in a district general hospital in a general gastroenterology ward. So it's very difficult to make comparisons between those two sites.
And that is in fact one of the weaknesses of the Atlas of Variation is if you compare crude intensive care unit admission rates with a transplant centre and a DGH, of course the transplant centre are going to be taking more patients to an intensive care unit because they're a different patient group. It doesn't mean there's not good care happening in district general hospitals.
Yeah, and it is important to understand where the information comes from, and the information comes from the coding that's done by non-clinicians after a hospital admission, and obviously there is a possibility that the way, although they try and make coding as consistent as possible, there are differences, and so you cannot necessarily be sure that the differences noted in the report are actually differences in care. some of that could come from a difference in the way that the coding is done. And so that's, I think, whenever you're looking at the big level data, and that would be the same whether it was from Scotland, Wales or England, that it's the, you know, the data comes from somewhere, and how robust that process is will affect the quality of the data that comes out.
Although it is fair to say there is variation in practice and outcomes.
And then in terms of palliative care, I think it might be useful just to put a paragraph of your report up on the screen so everyone can see it. It's EXPG 5043, please, and it's page 19. The last paragraph, please, Sally. I'm going to pick up the point about the developments that have occurred and measures that can be taken to improve things. But you've said this: the provision of palliative care for patients with advanced liver disease remains patchy across the UK and is contingent upon local interest, expertise and resource. The patient and carer experience of healthcare for advanced liver disease remains frequently poor, reflecting an illness trajectory typically characterised by recurrent and prolonged unplanned hospital admissions, a high burden of untreated physical and psychological symptoms, considerable social stigma and suboptimal end-of-life care. That, I think, reflects your views of the provision of palliative care across the UK.
Yes.
And
Yes.
just to emphasise, that's across the UK. It's the experience in England, Scotland, Wales and Northern Ireland.
Yes.
Yes, to the best of our knowledge.
Yeah,
yes.
none of us, I think, have worked in Wales or Northern Ireland, but there's nothing to suggest that it would be.
Thank you. That can go down. We've talked a lot today about the barriers to accessing palliative care and the difficulties and the extent of the provision. In your report, you've identified several measures that could be used to overcome those barriers. We've touched on a few of them as we've gone along, but I'd like to take them in a slightly more, a more structured way. First of all, you've identified the need for support within national specialty organisations and the need for clinical practice guidelines. First of all, how would clearer guidelines help clinicians in the palliative care context?
So, as we've mentioned before, palliative care in liver disease is a relatively new development. Palliative care evolved initially from patients with malignant disease. There has also traditionally and historically been an opposite problem also almost in hepatology, that certain physicians have been unnecessarily nihilistic about the prognosis in liver disease and may not afford patients intensive care when it would be appropriate. So to provide some background, hepatology as a specialty have often felt the need to advocate for their patients because historically they perhaps didn't always get the best care. On that background, it is very helpful to give physicians managing liver disease an idea of that their practice is consistent with best practice more widely, that they are managing to give some guidance in how to do things well, as this didn't, for a lot of colleagues, this won't have represented part of their day-to-day work until very recently. So when to use it and how to use it. And also the use of guidelines does make things more measurable and auditable. So it does allow people to measure what they're doing, measure progress, and identify whether they have services within their institution to deliver these elements of care. So if you have guidelines or standards which are nationally published and ideally measurable, I think it is much easier to disseminate good practice.
The inquiry's heard evidence over the last few weeks in a different context about guidelines and two particular difficulties. Firstly, the dissemination of guidelines, and secondly, the adherence, the compliance with guidelines. What steps do you think are needed, first of all, once guidelines are produced, to ensure they reach the right people?
So I think publication is important. I think presentation at national meetings is important. The latest iteration of the British Society of Gastroenterology guidelines for the management of patients with ascites has for the first time now included palliative care provision and discussion for patients who have refractory ascites but who are not candidates for liver transplantation, which represents a huge step forward in recognising this as part of disease management, and is really the first national guideline on ascites to recognise that. Increasing presence at conferences, both within our specialty and more generally, but also more widely, and I think an increased knowledge in general society of a liver disease and advanced liver disease and the consequences of it, and the power of patients to advocate for elements of their care that they may not have previously been aware were available.
And secondly, the adherence and the compliance with guidelines. What steps do you think are needed to support, encourage, ensure compliance and adherence?
I mean, one of the challenges is that actually, because there isn't very much high quality research in this field, it's actually quite difficult to produce guidelines. The American Association for the Study of the Liver has literally, in February actually, just published guidance for palliative care and liver disease, and they steered away from producing guidelines because the evidence base isn't necessarily there to tell people what they have to do. And I think that is one of the challenges at the moment. There are lots and lots of guidelines within medicine, and how you get people to be aware of them and adhere to all of the different ones is a challenge. The IQILS, which is a new accreditation process being brought in by the Royal College of Physicians for hepatology services, I think is one way of trying to encourage services to provide palliative care. So the IQILS is a list of
Just in terms of the acronym, it's Improving Quality in Liver Services Scheme.
Yes.
You carry on.
Thank you for that. And so the idea of that is that units will try to gain accreditation. For that, they have to meet particular targets, and a couple of the targets do relate to palliative care measures. One is the percentage of patients who have day case paracentesis as opposed to during an admission. Another one is that advanced care planning there is a method for ensuring that advanced care planning is occurring. An MDT would be probably the easiest way of showing that. And once you get that accreditation, it then shows that your service is meeting these targets. And it's early days. At the moment, there's only a couple of units in the country, I think 3 now, that have got second level accreditation. But as it becomes more aspirational, as more units become aware of it and are trying to meet those targets, I think that is one way of trying to improve the adherence to guidance. But as I say, it is difficult because guidelines suggest you've got strong evidence to tell you what you have to be doing, and you don't necessarily have that yet.
Although, I mean, it's hugely encouraging to see palliative care metrics within the IQILS guidelines, and it is a scheme that, particularly if in future it was associated to funding and tariffs, that often the reality is of getting funders, commissioners to pay attention to the importance of the service. There needs to be some kind of cost benefit to institutions for employing it, for those services to become more widespread.
And I think in relation to the cost-benefit question and the financial side of it, you've identified the Commissioning for Quality and Innovation Payment Framework as another mechanism possibly to encourage adherence to guidance. What is the framework, and how does it work? How do those payments work, roughly?
So SEQUINs, which would be the acronym, are a way in which commissioners can financially encourage healthcare institutions to perform a measured, targeted thing with a financial reward. So, for example, there is a SEQUIN for patients who are admitted to hospital, have an assessment for their risk of a blood clot and the percentage of patients that are prescribed a medication to prevent that is a quite easily measurable thing that has improved the rates of patients not getting blood clots when they're in hospital. As you know, palliative care is more nuanced and complex. It is more difficult to kind of directly transpose that. However, there are areas in which you can do that. Hazel's mentioned the availability of a day case paracentesis unit, and there's reasonably good evidence that patients who have that service available to them have lower amounts of time in hospital, are more likely to die in a place of their choosing, to have lower overall healthcare costs and a higher amount of time out of a hospital bed within their last year of life. And we know that those things are valued by patients and carers. So similarly, the ability to deliver multidisciplinary care and anticipatory care planning through a multidisciplinary team meeting is something that is objective and recognisable. So although it is difficult, I don't think it is impossible. And whilst the evidence it's a fledgling subspecialty, there is an increasing body of evidence to demonstrate benefit of this to patients and carers. And I think it would be a useful way to improve equity of care across the United Kingdom.
There isn't a sequin for this at the moment.
There
So
isn't,
the idea
no.
would be that in the future that could become one.
Yes.
And that's just one way that I think healthcare systems
Yeah.
do understand
No,
and,
you're right.
need. So
Yes.
it's an aspirational idea that
Yes.
this would be one way to try and encourage.
And although it's difficult, I think there are things
we need a measurable
there are things you can catch onto. It's not.
Because for it to be a sequin, it has to be objective and measurable.
Yes.
Absolutely.
And so in palliative care, that might be tricky, but there are certain items that you think could be identified
the delivery of an ambulatory day case unit for patients with ascites, a document within your hospital that records anticipated care planning discussions and disseminates sealing of care decisions to the wider institution. The discussion about prognosis, the availability of specialist palliative care services to patients when it is required. I know we've talked about core and specialist differently, but the availability of specialist palliative care in cases of complex needs is far from ubiquitous. There are factors which are measurable. It's difficult, but it's not impossible.
And you spoke a moment ago about the need for a better evidence base in order to move things forwards. Can you outline for the inquiry what is needed by way of research more immediately to be able to feed into improving practice? What sort of issues are there that need to be addressed in research?
So it's a lot of there's the structural issues which we're talking about at the moment, and then there's the individual patient issues. So in terms of the structural issues, we're talking about experience, and we're using surrogates of outcomes to suggest things, but there is no kind of widespread data collection on the provision of palliative care in liver disease in the UK currently. There's no obligation for trusts delivering care for patients with the liver disease to code or submit data around that. And so by starting with some basic database work to measure service provision and service gaps, you'll be better able to plug those holes. On an individual basis, how we best manage physical symptoms, how we best optimise quality of life is something that it's actually starting to increase in both the United Kingdom and the States. We, just a couple of weeks ago, through our specialist interest group, we were successful. There was success in achieving a grant for a fully powered study comparing quality of life outcomes in patients who have a long-term abdominal drain compared to repeated paracentesis procedures, looking at the determinants of quality of life and looking at patient selection and which interventions may be better for different types of patients. So this is a new area, but it is starting to gain traction. Sorry, I'm not sure if you have.
I think the research is out there at the moment. There's a lot of qualitative research, which is very valuable in terms of understanding patient experience. There's not a lot of research comparing different models of care, trying to work out what is the most efficient way of providing care, what is the most effective for patients. And a lot of that comes from not necessarily understanding what's happening at the moment. So, as I say, the research that I did show that patients with hepatocellular cancer are more likely to get palliative care than patients who don't. What we don't know is really why that is. We can sort of try and suggest why that might be, but there isn't really the research to support that yet. And I think that's one of the challenges, unfortunately, with any palliative care research. It has been difficult to show what what is the best option, because the measurable outcomes are more challenging than they are for a trial where you can get numerical outcomes, because actually the quality of life, the patient experience is more difficult to measure.
So we've discussed the measurable outcomes and the possible use of that and the research that's needed. What then is the role of subspecialty societies in trying to ensure adherence to guidance or the development of guidelines once that is an option? What's their role?
It's about being visible, and I think that the special interest group, just the fact that there is one is a significant improvement. It's the acknowledgement that this is an area of hepatology where there is a need, and so I think that's been really important, the fact that it exists, that anyone can join, whether they're from a palliative, and we've really encouraged membership from not just the hepatology community, that it's palliative care, it's nursing, it's doctors, and that's helpful. And actually recently we've been asked to present a joint webinar for the BSG, which is the British Society of Gastroenterology, and Basel, British Association for the Study of the Liver, and that's something that clinicians are able to listen to. Ben has been giving talks as part of a trainee programme of education. I think in the past, having a talk on palliative care and liver disease as part of this would be, not something that we would have ever considered. And actually, just over the last few years, the visibility of this as a subspecialty within hepatology has really grown, and I think that has come from having the special interest group there. And there's the same in America. They have a similar group that's been set up by clinicians with an interest, but then the idea is to try and disseminate to people who maybe don't have an initial interest in it, but we can show the value.
It's all that's the nail on the head, isn't it? Showing the value. Adherence to guidelines and adherence to guidance is always going to be very difficult if it's this is something you must do, this is a box you need to tick. It is about explaining to colleagues and clinicians and empowering patients that this is a beneficial thing, this is useful, there is evidence supporting it, this is the right thing to do for your patients because it's the right thing to do for your patients. So broadening the education and the discussion and the increased visibility at conferences is the way this is achieved in reality, and I think that's the pragmatic way to get it through. I mean, there's an invited seminar in this year's British Society of Gastroenterology, which is a really big kind of international conference on palliative care and liver disease, which would have been unheard of 5 years ago. So it is an area that I have some optimism is changing.
It's the same for you, isn't it? In Scotland, there've been a lot more interest.
Yeah, absolutely. I think if I could add to what you've already, I absolutely agree with what you've said. In terms of the offshoots of subspecialty societies advocating guidance, we've talked about dissemination amongst the clinical community quite a lot, but I think there is an offshoot of that in that charitable organisations can use these guidelines to try, and you mentioned empowering patients. I think demonstrating to patients and giving them the opportunity to say, I am aware of this document, this is what I deserve, is, I think, something that charitable organisations really welcome the opportunity to do. And I know that the British Liver Trust has a patient charter, and they have minimum standards that they suggest that patients should be asking for when they are cared for with their liver disease. And so I think that's another benefit of there being high-level guidance that is then disseminated not just to clinicians but also to charities and other advocacy groups that can help empower and support patients.
I want to come back to the patient perspective in just a moment, but in your report you've also identified the need to integrate palliative care competencies into hepatology. From a training perspective, what would that require?
So As a hepatologist and gastroenterologist, people, throughout my training, people invested a lot of time in my ability to learn practical procedures. So I got a lot of training on how to do endoscopy and colonoscopy, and it was very much taught as a skill, and it was measurable, and you could tell when you were getting good at it. The same isn't true for the skills that are required of a that are the core palliative medicine skills that are absolutely implicit to your job if you're managing patients with liver disease, regardless of whether you're a specialist in palliative care or not. And there needs to be an explicit change in the hepatology training curriculum to achieve that. So currently, trainees going through their training have to provide evidence of competency in certain areas. So it could be a practical procedure, it could be your understanding of a disease area and its treatment. And currently, the higher specialist training curriculum for hepatology and gastroenterology does not have specific palliative medicine competencies within it. So you can get through your training without providing evidence of competence in that area. And it is something that is teachable and needs practice in the same way that endoscopy does. So, but through that very simple change, you would require trainees to both acquire formal training in it and demonstrate evidence of competency in it. It is now added to the general internal medicine curriculum, which most liver and gastroenterology specialists do as well, but that in a much broader sense, and in a sense that's not specific to liver disease.
So who do you consider needs to take responsibility for that core palliative care training with specialties for hepatology, gastroenterology? Where does the responsibility lie?
I think the training body for gastroenterology and hepatology has to lead it, absolutely. Yeah. If I could speak from a palliative medicine point of view, because I think I have learned an awful lot about liver disease through my day-to-day working, and it's not necessarily skills that I learnt in palliative medicine specialty training, but there has been a change in palliative medicine specialty training very recently, such that in years to come, the palliative medicine consultants of the future will be dual accredited, and by that I mean they have all of the skills that are required to be a palliative medicine consultant, but they will also be exposed continually through their training to the end in general medical specialties and general medical training, which will give them, I think, increased exposure to people coming into hospital with decompensated liver disease, and they will have much more interaction with gastroenterology and hepatology teams in their day-to-day working practice, and I think that will lead to increased skills and knowledge and competence that they have to demonstrate as part of their training before they can progress.
That's obviously training in the early years. What do you then do about the people who are already in practice?
Yeah, I mean it's a very good point. There are mechanisms for revalidation that we need to, as consultants, that we need to submit every 5 years. There's the requirements for that don't really revolve around specific competencies, but more around your general practice and feedback from colleagues and patients. Most physicians are quite open to self-improvement and education, and offering, as we have through the SIG, increasing frequency of webinars, written resources, increased representation at conferences. You would hope there would be a gradual change. How you enforce, as it were, is more difficult because no areas of our practice are.
I think it's important to recognise that people have different skills, and there will be people within a department who are probably better placed to take on more of this role. And so it's not necessarily going to be a case of getting everyone up to the same level, because in the same way that there'll be some people who are very good at endoscopy and other people who are not as good, that will be the case with palliative care. And whilst yes, people need to improve their knowledge and skills through attending training, actually just recognition that maybe they're not the best person to have those conversations, but they know who is also part of it as well, because I think you'll never get everybody up to the same level, and some people are just naturally probably better placed to focus more of their time on providing this type of service.
I want to move then to the more patient perspective, if I may. You identify the need for improved communication of disease trajectory and prognosis. The inquiry's heard evidence from people who've cleared their hepatitis C, who may or may not have some degree of liver disease and then have been discharged from hepatology follow-up. How should those patients be accessing palliative care provision?
So, there will, as in a group with advanced liver disease that have had hepatitis C treatment and then were discharged from hepatology?
It's a question I've been asked to ask you from core participants. It includes those who may or may not have some degree of liver disease, whether that's at an advanced stage or not. How do you talked about early planning, anticipatory care planning at the earliest stage?
So, I think it's important to emphasise if you have hepatitis C treated and that is your only risk factor for liver disease, and it is treated and you are not cirrhotic or you don't have advanced fibrosis of the liver, it is reasonable to discharge that person from a hepatology service, because once the hepatitis C is cleared, you won't inevitably develop what we've been talking about today. In terms of if there's participants that have got very advanced liver disease, despite having their hepatitis C treated, that wouldn't be standard practice. So
you would expect them to be under hepatology
if you've got, I think it is reasonable to discharge patients who have had fully treated hepatitis C and do not have ongoing liver disease, because there's nothing and the need for palliative care and prognostic discussions is not relevant in that group, because the hepatitis C has been treated and the liver has a remarkable ability to recover. If it's in a group where you've had your hepatitis C treated, but you have ongoing cirrhosis or advanced fibrosis or decompensated cirrhosis, that wouldn't be standard practice. So patients who have already developed advanced liver disease as a sequelae of their hepatitis C should really still be under ongoing hepatology care.
And through that hepatology care is how they would access the
and it can be, and that's where we've talked about it, it can come from the physicians, but in theory, patients can ask for palliative care referral, but that will depend on the patient's ability to advocate for themselves, and that can be difficult, particularly if there is that distrust with healthcare providers. So in theory, a patient should be able to ask their GP for referral to community palliative care services, or to ask their hepatologist for referral to the palliative care team. How that request is met and responded to will, unfortunately, that will depend on the individual looking after that patient.
And in terms of a patient advocating for themselves and simply understanding their situation, you've also referred to the need for communication aids. What were you identifying there that would be useful?
So I think there are communication aids that are useful for clinicians. It is like we've just said, it is just like endoscopy and surgery is a skill. Having these conversations is a skill, and having a framework to undertake these conversations and do them well is important. And so there are frameworks for clinicians to frame difficult conversations, either around bad news or uncertain prognosis or anticipatory care planning. But I think it's also important to have communication aids for patients to be able to advocate for themselves within a clinical environment. Hospital clinics, we've spoke a lot about best case scenarios today. The reality is hospital appointments are often rushed. They can be intimidating for patients. They're short. A follow-up is often the reality of the pressures that the NHS is under, means that follow-up and time for follow-up isn't always as clinicians would like it. So one of the developments has been from the Royal Free Hospital, which has been the development of a question prompt list, which is sent to patients prior to their appointment with a specialist, where they can look at the kind of questions that some other patients might ask, questions that might be appropriate to them, and are given an explicit opportunity to ask those within a clinic consultation. So I think those kind of aids, both to help patients in what can be an intimidating environment, but also to assist clinicians, are helpful. I'm not sure if you'd have.
There are other written resources. So we talked about the British Liver Trust. They have information that we both worked on the website just to explain to patients what palliative care is and explain what it can do. And that can potentially help empower people to be able to have these discussions with their clinicians. One of the difficulties is that health literacy in the general population actually is not always particularly good. We like providing written resources for our patients because that's relatively easy to do, and whilst we do try to make sure that the language used would be reasonably easily read by a non-clinician, actually for some of our patients where the reading level is such that these leaflets are not very helpful, I think we do need to move towards being a little bit more inventive with how we give patients information, and there has been some really interesting work looking at using videos in the States very recently where they actually used scenarios to try and improve patients' understanding of what resuscitation means, to then be able to have more meaningful discussions with patients because they have a better picture of what we're talking about, because clinicians often assume a level of understanding that isn't actually that accurate. So then to try and start those conversations can be very difficult. So I think it's in moving forwards just about being a little bit more inventive and thinking about trying to make sure that we're meeting the needs of patients, whatever their sort of education level and degree of health literacy is, will be helpful.
So I have about another 10 minutes of questions that I would like to ask the panel, and I'm conscious then we will need to take a short break for those behind me to feed in any further questions. I don't know, so whether you want me to continue for 10 minutes and then take our lunch break, or whether we should break.
Well, how accurate do you think the 10 minutes will be?
So I'm confident that it will indeed be 10 minutes. I suspect it might even be a little shorter. But perhaps that's famous words from Council.
Well, I think, put it this way, you could have your lunch now, but it'll delay proceedings a bit later, or you can take your lunch after another 10 minutes.
I'm very happy to proceed.
That's what I hoped you might say. And there being no dissent.
That's fine.
Let's do that.
I'll do my best to be 10 minutes. We spoke earlier about multidisciplinary team meetings. First of all, what role do you think patients have in those MDT meetings, and what role should they have when it's addressing palliative care matters?
I wonder if I might start with that and then you can add. So I'm involved in a monthly advanced liver disease MDT as one of the participants. I think there would be immeasurable value to a patient being present for those discussions, because ultimately they need to be, one of my colleagues speaks of co-authored decisions, so hearing a patient's view and the clinicians and those around them in the multidisciplinary team. What is really difficult is how to try and build that into the models of care that we provide and the pattern of clinicians' days. And in order to invite a patient along to those meetings, it would be really quite difficult logistically. That said, it's not an excuse for not doing it. And so I think trying to think creatively about making sure that the patient and their caregiver is involved in some way, shape or form in the multidisciplinary discussions is really important. So very often my colleagues, my hepatology colleagues, will bring a patient to that meeting for discussion that they have had the opportunity to speak with in a clinic, for example, and then we'll bring the information from the patient as to what their wishes are, and then we'll have a general discussion about what the right thing might be to do for that patient. So it's very difficult logistically, but I think it's incredibly important that the patient's voice is heard in these discussions. And I wonder if Ben or Hazel, you have any thoughts about that in terms of you being
our
leading these
advanced liver
meetings?
disease MDT is similar. Its cases are brought by the patient's primary physician, and their needs are discussed and they're triaged to the most appropriate specialist, for example, a dietitian for issues of frailty or malnutrition, or a physiotherapist, or a palliative medicine physician if there's particularly difficult symptom control issues. And the physicians discuss about what may be an appropriate anticipatory care plan, and that feeds into a subsequent discussion with the patient. How we get the patient more directly involved in that is a real challenge, because the numbers are huge. Liver disease is third commonest cause of death in the UK, the commonest cause in people of working age. and how, so we're talking a considerable volume, and so how we do this in a way that's achievable and deliverable to a very growing population of patients is a real challenge.
And the reality is it may not be what everybody would want, because actually for some people sitting in a room full of potentially 8 clinicians or of varying backgrounds can be incredibly intimidating. And I think that it is really important to be aware that the patient group is very variable. Now, there'll be some people who are confident in that environment and are very happy to put across their point of view and would feel able to do that. There'll be other people who actually the nature of that environment will mean they will be less able to say what they want. If what they're hearing isn't in line with their views, they may feel kind of pushed into something which isn't in line with their wishes. So although you would think that a meeting about a patient should definitely involve that patient, it's not necessarily the right thing. And that's why I think the one size fits all, we'd have to be very careful with that, because say a lot of our patients, they haven't had good experiences with healthcare workers. They don't necessarily feel confident in that environment. And a room full of 8 people, no matter how friendly they are, and the fact that they have the patient's, wishes at the heart of what they're doing, sometimes having the conversation with the patient beforehand, so you have an idea as a clinician on a one-to-one basis what the patient might want. You then go and speak to experts who may know the patient through different means, to speak about what is possible, what is not possible, particularly with transplant. You don't necessarily want to bring up a topic of transplant with a patient where it's very clear that isn't going to be appropriate, because you're almost raising their expectations only to bring them back down again. But then once you've had the meeting, it's not a case that we make a decision and then that's what it is set in stone. It is an iterative process, and you'll then go back to the patient, potentially talk about what the meeting has discussed, and then you may change your views again in the future.
A lot of our MDTs are around managing a very limited resource, and which patient would benefit most from the very limited time that the palliative medicine specialists have, the dietitians, the physiotherapists. Yeah.
Who should attend those MDTs? You've described it in your report as a very achievable goal for departments with constrained resources, but who should be attending those MDTs?
So our MDT is a 1 hour a month meeting attended by hepatologists, specialist nurses. There's representation from community palliative care, from the hospice and hospital palliative care. There's representation from an alcohol nurse, because the most frequent cause of liver disease that we see, and there's representation from allied healthcare professionals who often deliver the interventions that can impact on quality of life. So physiotherapy, dietetics, occupational therapy, these can actually be therapeutic differences. So that's what our MDT looks like, but I don't think it has to be as comprehensive as that for it to be meaningful. I think you can have smaller cohorts. I'm not sure what yours looks like in Glasgow.
Yeah, very similar. We don't have hospice representation, but I attend on behalf of palliative medicine, knowing that I have close links with my community colleagues, so I can then make links if need be. We also have somebody who advocates for financial assessment for patients, because quite a lot of our patients in the area that we serve come from quite socioeconomically deprived parts of Glasgow and beyond. So, but yeah, I would agree. I think the core participants are probably making sure that their hepatology, the wider hepatology team, and then I think someone from palliative medicine or palliative care would be very helpful.
And your team has included someone to deal with the financial needs as well?
Yeah.
That's quite unusual, I would say. I think having someone who is able to attend a meeting regularly from social services or that would be very difficult to achieve in a lot of places.
Do you think it would be valuable if there was that regular provision of somebody from social services or the local council or the extended social provision?
I think,
Yes,
yeah.
I do.
Yeah, it'd be hugely valuable, but you don't want to sort of... Yeah, the most important thing that is it starts in some form and evolves.
Yeah.
It's still a minority of hospitals that run an advanced liver disease MDT.
And I think part of it is just knowing where to signpost people. So you may not be able to have someone from finances coming, but knowing what resources are available in your environment. Because one of the problems with financial resources is it can be very difficult to access them if your literacy level is low, because the forms that need to be completed are very often quite challenging. And so these services, a big part of what they do is help patients to complete the paperwork correctly so that they are able to access what they are, is rightfully theirs to have. So it may not be a case of them being at the meeting, but as long as we know that that is a problem from speaking to the patient, or something that is concerning them, and maybe meaning that they're not able to engage as much with the healthcare side of things because they've got financial concerns, but we know that there are charities available locally who can help them with the completion of paperwork, that can be very valuable.
We spoke earlier about comorbidities arising from hepatitis C particularly. What scope should there be for other specialists to attend the MDT? For example, the comorbidities particularly were flagged with things like diabetes, renal insufficiency, depression, cardiovascular disorders. What scope should there be for other specialists to attend the MDT?
I don't think any MDT would object to specialists from any of those subspecialty areas attending. I think the reality is it would be perhaps logistically difficult
you might do it. I was one bit. I think although these things are relevant to the core participants here, it may be that on a wider level, the majority of patients who have liver disease can be mostly managed by a hepatologist. There may be examples where it would be important to ask another specialist to attend a particular MDT meeting for a particular patient, but I think having them as a core part of the MDT in most cases is probably not required.
And joined-up working happens outside of MDTs all the time. You're on the phone to your colleagues all of the time. It doesn't have to be within that 1 hour a month forum. It can happen informally and...
I think regardless of the hospital setting you work in, you have links with other specialties, and they are very accessible. So if there was a particular issue pertaining to a complication from hepatitis C treatment, then there would be a specialist who you'd be able to access out with the MDT.
I've been asked to explore with you whether there's a role for something called Health Amendment Act cards, which are in Ireland, where patients with advanced liver disease who've been infected by blood or blood products are given priority access to healthcare, and the cards are used to facilitate liaison officers who can step in and help if a registrant has problems accessing treatment or services. Do you think they would be useful in that context of trying to access multiple, having the MDT but also needing access to other specialists?
I mean, I think patients from a wide spectrum of liver disease would benefit from healthcare advocacy. More commonly, our patients are from socially disadvantaged groups and access healthcare more circuitously than in other disease states. So I'm not sure how such a system would work, particularly in relation to this, but I think liver disease more globally benefits from advocacy, and but I wouldn't have said it would be specific to the infected blood.
I'm not familiar with that process, and I think the challenges are there at the moment. Accessing healthcare for lots of people for lots of different reasons is difficult, and how you decide who is able to have that might be challenging. But I'm not familiar with that process at all.
And finally, we spoke earlier about the difficulties of information sharing and the systems that, at the moment, I think the existing systems that don't enable good information sharing between all the multiple people involved in palliative care. Do you have a view on what should be done instead, what the ideal would be?
So this isn't mentioned in our report, but I do wonder, and this is very much a personal view, that the repositories of information about people's healthcare and their needs very much sits with the clinical teams. And I think that there should be a shift, and it is already happening in some specialties. I know that diabetes have a lot of online self-management systems that are hugely empowering for patients, and I think patients feel the benefit of that. I wonder if the information and sat with the patient and their families, that might be a really good way by which they are able to advocate for themselves, so that rather than coming into hospital and being reliant on a clinical team looking up their information on a system that they don't have access to, them actually being able to say, this is my information, this is what I understand, I think would be really helpful. And I think that would fit not just in this context, but across all healthcare systems.
Dr. Woodland, Dr. Hudson, do you have anything to add on that?
I think, unfortunately, one of the big challenges is that whilst the NHS is a big organisation, individual hospitals work quite separately when it comes to IT services. And as the GPs are a little bit more joined up, but the hospital systems often don't talk to the GP systems. The problem is that because everyone has got different systems between different hospitals, trying to have a national way of everything talking to each other is extremely difficult without a very, very large input of money, which I think is not available.
Although there are, again, simple things you can do to make some difference. So one of the biggest impacts we made locally was once we'd had our MDT and had the discussion with the patient and we'd agreed on a sensible ceiling of care, that there was a flag put on the A&E computer system that this patient's been discussed. When they come in at 2 o'clock in the morning with a variceal bleed, there's some guidance for those clinicians who have never met the patient on how an MDT has decided, and the discussions with the patients, and that floats to the top of the electronic notes. So although the wider things are aspirational and important, prior to that point, there's things individual hospital trusts can achieve to improve communication within a single organisation.
Yeah, and I would definitely agree with Fiona that having patients having access to their information is
absolutely.
And when I've seen that done in hospitals, it is very empowering that patients don't have to wait for somebody to write with their results; they're able to access them.
Yeah, patients owning their information
Yeah.
is a hugely important step.
So those are the questions I have for the panel. I anticipate there will be a number of questions from those behind me. So I wonder if we take our full lunch break and then ask the panel to return.
Yes, well,
if we can.
Would 2:10 be a sufficient time for you, do you think?
Yes, sir, absolutely.
So we'll take a break now until 2:10. At that stage, I don't know how long you'll be detained after that. It depends upon the number of questions which Council has to ask. The process is that those who are core participants in the inquiry are entitled to ask Council to raise questions through their legal representatives. And that process will take place, obviously, over lunch, to the extent it hasn't taken place already. And we'll come back and she'll field those questions and you'll have them to answer. Maybe short, maybe long, don't know. But that's the anticipatory plan, using your words. So, 2:10.
Thank you.
Thank you.